All right, everyone, we're right here at 4 p.m. Eastern time, so we'll go and get started. We'll run through introductions as quickly as we can and then turn things over to Dr. Holland, who will be leading our session today. So good afternoon, everyone. I'm Dr. Samuel Collins. I'm the UVA Division of Outreach and ECHO Research Director. The Division of Outreach is housed here at the University of Virginia in the Department of Psychiatry and Neurobehavioral Sciences. Our Division of Outreach works to improve access to education and care addressing mental health and substance use disorders through cultural and community-driven approaches and targeted provider education. Dr. Larry Merkel, who's a professor of psychiatry and neurobehavioral sciences, serves as our medical director. We're grateful for collaboration and support from the Virginia Neonatal and Perinatal Collaborative, Postpartum Support Virginia, and the Blue Ridge Poison Center today, along with funding from the Virginia Department of Health. So what's an ECHO? If it's your first time joining us, simply put, it's a means of delivering subject matter expertise to clinicians and relevant community members. By doing this online, we can democratize knowledge. At UVA, we apply the model to both small didactic learning communities and in larger webinar formats like what we're doing today. So a couple of notes on the folks that helped us distribute this series and then also serve as a resource here in the Commonwealth, tangentially and directly related to NOWS. Postpartum Support Virginia is a nonprofit organization established to educate families, healthcare providers, and community members about perinatal mood and anxiety disorders. They provide free direct services, including a year-round warm line, virtual and in-person social support groups, and a peer mentor program and care coordination program. Learn more about their work at postpartumva.org. And next is the Virginia Neonatal Perinatal Collaborative. They're the statewide perinatal quality collaborative working to improve outcomes for mothers and babies across the Commonwealth. Through all their quality improvement projects, the VNPC creates connection and advocacy working with clinical and community partners. Learn more about the VNPC at govnpc.org. And then lastly, the Blue Ridge Poison Center, or the BRPC. It's housed right here at Virginia, and it's staffed by nurses and doctors specially trained to handle exposures to all sorts of poisons, from everything from medicines to snake bites. Their experts are available by phone for immediate, confidential, and free treatment advice, and they're open 24 hours a day, every single day. And they also answer non-emergency questions about poisons and poison safety. So an invaluable resource for those of you who practice here in the Commonwealth. So again, some housekeeping items related directly to ECHOs. These are based around collaborative exchange. We have frequent questions and answers. So there'll be a significant time allotted for Q&A today. However, please do note that you can post resources or observations and then your questions as well in the chat as they come along. And we also have a number of our panelists and myself monitoring the chat to note these questions and sometimes to engage them. So not a big deal to have sidebar conversations and resources shared in the chat, and then also to go ahead and post things again for us to circle back to later in the presentation. Important note that I'm sure many of you need to know. We do have CME credit available, so there'll be a slide at the end of the presentation, and the CME info will be included with a follow-up email that'll be sent to all participants today. The contact info for the CME office is present, so please follow up with them rather than any of us serving on the panel or moderating the ECHO today. Also, do note that this session's recorded, and so that goes out with the follow-up email as well. Today, we're considering the Eat, Sleep, Console model, and then we'll be looking, I think, some at medication management, and then I know we'll be looking into best practices around discharge. So this is part 2 of 3 in our series, and part 3 is coming up next week, same time, same link, and we'll be discussing breastfeeding, which includes follow-up and outcomes. Again, that's Thursday, August 31st at 4 p.m. Eastern, following the same link. So we hope to see you there. Lastly, I'll introduce our panelists and a few folks and then turn it over to them. I think leading our session today is Dr. Holland. She is an associate professor of pediatrics. She's also a board certified pediatric hospitalist. And then also joining us as a panelist and who will be helping me monitor the chat is Dr. Santina Zanelli. She's a UVA professor of pediatrics and a neonatologist here. And then working with us on the series, although I'm not sure if she's joining us for this one today, is Dr. Ann Kellums, who is a professor of pediatrics and also the director of our UVA breastfeeding clinic. a couple of notes about these folks and why I appreciate them so much. Drs. Hollins and Zanelli worked together with me on our big DEA project that many of you can check out. If you need 8 hours of opioid use education, it's free. And so did Dr. Kellums. It's free for all of our providers and prescribers here in the Commonwealth and at UVA. It's available on the UVA CME website. And I'm also grateful for this being our second year in a row that we've done the NOWS series. I know that a lot of things stay the same, but it's a constantly evolving clinical issue. So I'm so grateful for their work in training resident physicians and fellows, and for being, again, repeat outreach echo panelists. They make my job pretty easy. So with that said, I'll turn it over to Dr. Holland now. And if you have questions, feel free again to post them in the chat. Thanks, everyone.
Great, thank you. First off, I want to apologize for Dr. Kellums because I'm looking at the slide and realizing I'd left MD off of her name. So please know that that was an oversight. I am Eliza Holland. I'm one of the pediatric hospitalists. I am also working very closely with the VNPC on the Eliminating Bias in Dyad Care project, which is the identification and treatment of mothers with opioid use disorder, and then the continuum of care through treating their newborns and discharge. So that is an ongoing project, and you'll be hearing more about that later. Let's see. So today we're going to be talking about the Eat, Sleep, Console model, including what medicines we use, and then a lot about hospital discharge and follow-up needs. And as with Dr. Zanelli's talk, there will be case discussions. So some of these slides you guys saw last week or have seen in the past, but I think that they bear repeating. So this is a map looking at the increase in opioid overdose deaths between 2019 and 2020. And those areas that are in the darker orange had an increase of more than 40%. And you can see that Virginia is one of those states that had drug overdose rates that increased by over 40%. This graph goes a little bit farther out and shows some encouraging news. This is looking at overdose rates in just Virginia. And you can see that rates were stabilizing or maybe even decreasing some in 2022. But they're still significantly higher than they were in January of 2020. So we know that drug use and overdose continues to be a major problem. For what we're talking about today, we need to realize that women are impacted and treated very differently for pain. Although men are more likely to die from prescription overdoses, women are more likely to seek care for acute and chronic pain. So they're more likely to be prescribed opioids. And most importantly, they're more likely to be prescribed multiple medications. And we learned last week that combinations of medications can make neonatal abstinence syndrome worse. This slide from the CDC shows that about 7% of women report using prescription opioids when they're pregnant. Of those, almost a third say that no one talked to them about the potential effects of prescription opioids on their baby. 1 in 5 reported that they weren't using the prescription opioids as they were prescribed, so they were getting them from someone other than their doctor or using them for something other than pain. And over a quarter wanted to cut down or stop using. So what does opioid use disorder or drug use disorder look like in Virginia? This graph is from a state website, and it shows per quarter the number of women who deliver each year with drug use disorder. So keep in mind, these are only the women who report to their doctors that they have drug use disorder. This does not take into account babies that we find with NAS or NOWS after delivery for whom we didn't know that mom was using drugs. I don't know where the first quarter data is for 2022, but if we estimate that it's about the same, so about 400 women, you can see that 2022 is going to have the highest number of women with drug use disorder who delivered in this state. So over 1,800 women. And that number has been going up slowly every year. So Virginia overall is doing okay as far as its rate of neonatal abstinence syndrome. We're a little bit below the nationwide level of 6.3 per thousand newborn hospitalizations. We're at 5.7. And our neighbor, West Virginia, has 43.4 per thousand. So it would be great if that number were lower for us, but here we are. This graph looks at infants with a diagnosis of neonatal abstinence syndrome who were discharged from the University of Virginia over the past 5 years. And at first blush, it looks really great. Like, we're seeing maybe fewer babies with NAS, but I would take these numbers with a grain of salt. In 2018, UVA instituted the Eat, Sleep, Console method of treating these infants, and we started using less medication. And my concern is that if we're watching these children but didn't start them on medication, that we weren't billing them or coding them as NAS. So I think we're actually missing a lot of drug-exposed infants in these numbers, but that's something we're really going to need to drill down on. So my recommendation is, when we're seeing these children in the newborn nursery or on the floor in the NICU, even if we don't end up starting medication, to still identify them as having NAS or NOWS. So just another review from last week. Neonatal opioid withdrawal syndrome is a subset of neonatal abstinence syndrome. So it's really just for those infants who were exposed to opioids during pregnancy. It can include infants who were exposed to opioids with other medications, but if there was maternal use of any opioid medication, we should be identifying these children as having NOWS. And this diagnosis is not limited only to those neonates who require medication. There are 5 clinical signs that we're looking for to make this diagnosis. And it is excessive crying, if they're having disturbed sleep, tremors, increased muscle tone, and then GI dysfunction. So we think of that generally as formula intolerance or diarrhea, but it can also be poor feeding or a motor dysfunction or just ravenous appetites. So if we have infants with any 2 of those symptoms and a known opioid exposure in utero, we should be diagnosing them with NOWS. So the medications in top in the red box are the ones that we're really thinking about. So it's heroin, methadone, buprenorphine, and then other opioid prescription medications. And you can see in that first chart that the onset to withdrawal is generally sometime in the first 72 hours, although it can be a range. So this is the reasoning behind watching these children for 4 to 5 days in the nursery or on the pediatric floor to see if they're going to have withdrawal symptoms severe enough that we need to treat them with medication. It is really important for us to remember, and also to counsel our families, that the withdrawal symptoms can last for several weeks and sometimes a month or more. That doesn't mean that the babies need to stay in the hospital that entire time, but we do need to give really good anticipatory guidance on the type of symptoms that the families might see at home and what they can do. So case 1 is a 3-day-old who was born at term to a 30-year-old mother. Mom is currently incarcerated and is on medication-assisted treatment, buprenorphine. Where should the baby be admitted for care? Do these babies need to go to the NICU? And how would you monitor for withdrawal? So again, NOWS is a clinical diagnosis. It's nice to have the confirmation through all those methods that Dr. Zanelli mentioned last week. But if you have a suspicion, and especially if there is a known opioid use during pregnancy, then you can make that diagnosis. We are watching these babies in the hospital for at least 4 to 5 days. We really want to assess on the baby's schedule so as to minimize disruptions. We also want to get these babies at their physiologic peaks and nators. So if we're assessing a baby for fussiness right before they're due for a feed, we're really not going to get the best assessment. So we want to try to optimize the chances for success. We're really walking away from automatic NICU admissions unless they're complicating medical issues. We know that these babies do much better in environments where there's decreased stimulation. We need to aggressively involve lactation if it's a breastfeeding mother, speech therapy, occupational and physical therapy to help manage some of the withdrawal signs. And we want to encourage the families to be at the bedside as much as possible. We do need to, though, keep in mind that often it's hard for families to be at the bedside for 5 days straight, especially if you have a mom who is in active recovery and has her own appointments, doctor's appointments that she needs to go to. So as much as we can keep them engaged, but also offering them a little grace for the other things that are going on in their lives. So I was reading the paper this spring and I saw this article and I thought, oh my gosh, this is so exciting. There's a brand new way to treat these babies. So I eagerly jump into the article to find out that they're talking about Eat, Sleep, Console, which about which the first published studies were put out in 2017. And I said UVA started using Eat, Sleep, Console as a way to assess and treat these babies in 2018. So the mainstream media is about 5 years behind where we are. But still, it's nice to see it in the popular press, and I hope that it helps more people understand what we're doing and what the scope of the problem is. So when I talk about Eat, Sleep, Console, I'm talking about a more recent way to assess these babies. It really looks at the functional impact of withdrawal symptoms, and you're looking at basically 3 domains. Is the infant feeding well? So a breastfeeding baby is that a baby who's feeding 8 to 12 times a day with good latch and transfer. And if they're bottle feeding, are they taking at least an ounce at a time? Can they sleep for more than an hour undisturbed? And can they be consoled in 10 minutes or less with good, appropriate comfort measures? I'm not talking about swaddling the baby and putting them back in the crib. It may be doing skin to skin or rocking with the baby. And we'll go more into that in a few slides. So thinking about the former tools that we used to use to figure out how these babies were doing. There was the Finnegan that looked at 32 different items, and then the modified Finnegan, which dropped it down to 21, and then the simplified, which still looked at 10 different items, looking at CNS, GI, and metabolic. And then there was the Lipschitz that looked at 11 items. And the problem is that these scoring tools, in addition to having a number of different boxes that you need to look at, there is a lot of variability depending on who was doing the scoring. The beautiful thing about Eat, Sleep, Console is that it is simple. We're looking at 3 domains and they're very easily quantifiable. So this came out of, the Eat, Sleep, Console method came out of Yale. A group was looking at their medication use and length of stay for their infants who were in utero opioid exposed. And at the start of looking at their baseline data from 2008 to 2010, they had 96% of their infants who were opioid exposed were getting scheduled morphine. So the first thing they did was look at non-pharmacologic care and standardizing that. And then their next intervention was trying not to put these children in the NICU, trying to get them directly to the nursery or to the pediatric floor. And with those interventions, they were able to drop their medication use to 73%. Then they started to look at Eat, Sleep, Console as an assessment versus the modified Finnegan. And you can see when they did that, that their number of babies that needed morphine started to drop. And then they changed the way that they were using the morphine and eventually transitioned to morphine as needed. And you can see they had a significant drop in the number of babies that were requiring medication. Along with this, they had a significant drop in the length of stay, which is great, right? What we want to do as much as possible is normalize life for these babies and their families. So when we're talking about non-pharmacologic care, we're talking about things other than medications. And this should be the first line therapy in all cases of NAS and NOWS. The nice thing about it is family centered. We are hopefully giving the parents the tools that they need to care for and console these babies when they go home. How do you make your environment quiet? How do you recognize their feeding cues? How can you swaddle and calm them? It takes the emphasis away from the old model, which was, I feel like was, you did this to your baby, now we have to fix it with medication, to more, your infant is struggling with withdrawal, but we are going to teach you things that you are going to be able to do. And it can be really, really empowering. And again, trying to normalize the experience as much as possible. So one of the big things is decreased stimuli. I remember when I had my babies, my friends were like, make sure that child can sleep through all sorts of noise. So run the vacuum cleaner when they're asleep and have the radio on in the car. These babies with NOWS are not the children that you want to try to adjust to loud noises in the house. These are the babies that really need calm environments, so dark. When they're in the hospital, television off, try to decrease the ringer on the phone, don't be playing the radio, try not to have a lot of people coming in and out. Cluster the care so that you're on the baby schedule. Try not to wake this baby when they're sleeping. And then we're talking about supportive care, and this is where the parents can really get involved. So skin to skin, shushing, swaying, holding them in a side-lying position, doing really good tight swaddles. And then babies that are hard to calm, you can do some vertical rocking or some firm patting. And you want to show the families how to do this. So they're not not hurting the child, but just giving them some good reassuring pats. If you cannot have families at the bedside, this is a great use of cuddlers and volunteers. When I have medical students on service with me and we have babies with NOWS, I really try to get them to go in the afternoons and hold these babies. It's usually the best part of their day. So what about breastfeeding? This is a topic that Dr. Kellums is going to delve into more next week. So I'm just going to do a quick overview. So if mom is in medication-assisted treatment, she does not have HIV, and her nipples are intact, even if she has hepatitis C, she should be encouraged to breastfeed if that is the feeding decision that's best for her and her family. But again, it's very important, like these moms, if there's any other drugs on board, any other illicit drugs or something outside of their MAT, then we should do formula feeding because we don't want to introduce any other medications to the baby. If mom is in medication-assisted treatment and is breastfeeding, these babies actually tend to have less severe withdrawal symptoms and less of a need for pharmacologic intervention, probably because they're getting low concentrations of the methadone or the buprenorphine in the breast milk, and that is safe and can be very helpful. And then lactation support is going to be so critical for these moms. In addition to the normal difficulties that you can have with initiating breastfeeding, these babies may be disorganized and jittery because of their withdrawal symptoms. So you really need professional support in to help moms through this. If the family chooses to use formula or if you need to use formula because of other medications on board, going to a lower lactose formula initially may be helpful with some of the GI symptoms, the formula intolerance and the diarrhea. Know that weight gain is likely to be an issue due to both the withdrawal symptoms, their increased metabolic demand from the withdrawal, and the oromotor dysfunction that can come along with this. So these are babies that I would bump up to higher calorie feeds early. If you start to stall on weight gain, or definitely if you're getting weight loss, go to 22 or 24 calorie formula as quickly as possible. You want to get nutrition involved to help you with these decisions and to help the family learn what the different formula recipes are going to be. And you also want to get speech therapy engaged early, because they can be really helpful in teaching the families the best way to hold the baby and kind of the feeding cues and when the babies are overstimulated. And then if you're on 24 kcal formula and these babies are still not gaining weight as expected, I would go ahead and place an NG tube for supplementation until they get through their acute withdrawal period. So going back to our baby, he was monitored using the Eat, Sleep, Console method. He was feeding well and gaining weight on a 20-calorie formula. He was agitated, tremulous, and had increased muscle tone, but was easily consolable and was sleeping well. So we watched him, never felt like he required any medication. His foster mom was able to be at the bedside the entire time and felt comfortable taking him home when his observation period was over. So our second case is a 37 and 5 week infant whose mom had a pregnancy complicated by late presentation to prenatal care, maternal drug use and tobacco use, hepatitis C, and a breech presentation. At delivery, her drug screen was positive for cocaine, amphetamines, benzodiazepines, and opiates. He was admitted to the nursery and monitored using Eat, Sleep, Console. Formula feeding was advised for this mom as she was positive for multiple drugs. Day 1, he did okay, but day 2, he started to be more irritable, required constant holding, and was taking formula only sporadically. So he scored no in 2 domains. He was also sneezing and jittery and was 7.2% down from birth weight. So this graphic is from our flow chart that we use for Eat, Sleep, Console here. So on the left-hand side, you can see the different domains. Are they eating, sleeping, and consoled? And if you get all yeses, then you continue to monitor. If you have any no's, then you have a group meeting and you decide if there are things that could be done better as far as consoling, as far as the way that we're feeding the baby. And if we're still not seeing any improvement, then we start with morphine. And we start it as needed and then decide if it needs to be a scheduled medication. So morphine is preferred over methadone in this case because it's shorter acting. So you can use it as needed or you can schedule it, and it's quick on and quick off. So we start at 0.05 milligrams per kilogram per dose every 3 to 6 hours. And then you can go up by 0.01 milligrams per kilogram per dose up to twice a day. You can make that change twice a day, up to a max of 0.3 milligrams per kilogram per dose, or a total of 1.2 milligrams per kilogram per day. We use clonidine as our second line agent. So if we have gotten to a maximum dose of the morphine and we're still not getting good control, then we would add clonidine. Clonidine is also really helpful if there's benzodiazepines on board or as a first line medication in non-opioid exposed infants who are showing withdrawal symptoms. And we start that at 1 microgram per kilogram every 6 hours. And then we watch these babies, and as soon as we feel like their symptoms are controlled and they're at a steady state for 24 hours or so, then we start trying to wean off the medications. So when I was reviewing charts, I saw that some hospitals are using buprenorphine. And there was a 2019 meta-analysis that suggested that sublingual buprenorphine provided the shortest length of treatment and length of stay when compared to the older modalities of using clonidine, diluted tincture of opium, plus or minus clonidine, morphine, methadone, and phenobarbital. But it's really important to know that these studies use varying scoring measures. So there was a lot of variability in how these infants were scored and when they decided who needed medication. Morphine was scheduled in all of the studies in which it was tested head-to-head or looked at head-to-head against buprenorphine. The Eat, Sleep, Console protocol was still really early and was not included in this meta-analysis. The studies also did not look at the impact of non-pharmacologic care on length of stay, and it included some single-site studies, the results of which may be harder to generalize to various other populations and areas. So I really, like I said, we use morphine here, and that's what's recommended through the Eat, Sleep, Console method of assessment and treatment. So
which class is that? That's
Go ahead, Dr. Holland.
I'm sorry. So the infant in our case was transferred to the general peds service for further assessment and treatment. Mom was able to be at the bedside and did a great job getting him to console and sleep. Feeding remained an issue, so we increased the caloric density of his feeds, worked with speech. He continued to have no on his scores despite PRN morphine. And so then he was started on clonidine with the concern that his symptoms were more of benzo exposure predominant. After he was stable for a few days and gaining weight, his clonidine was weaned off and he went home on day of life 8 and was off all medications. So discharge planning is crucial. Good discharge planning is crucial for these families. And we really need to establish a safe care plan that begins prior to discharge and ideally prior to birth. It's a multidisciplinary team and cross-system collaboration, including the hospital team, the pediatricians or the providers who are going to follow these babies as outpatient. And these are patients that I would do a warm handoff and call and talk to the pediatrician. Bedside nurses who've been working closely with these families, social workers, discharge coordinators, and then community agencies. I have to say, I feel like all of these families get CPS referrals, but I think it's important to emphasize to families that if there are no other concerns, we're getting CPS involved to work as more of an outpatient coordinator and not because we feel like we need to take their babies away. So I think Dr. Zanelli showed this last week. This is just part of the brochure that we created for families who have babies with NAS. And it's just an overview of what symptoms we're going to be looking for, how long they need to stay in the hospital, and then what might happen. So again, the best case scenario is that mom is honest with her OB provider, and we can start this discharge planning and anticipatory guidance about the baby's hospital course and discharge even before delivery. But I have had a number of families who deliver a baby and then are shocked to find out that they're going to need to stay in the hospital for 4 or 5 days. So lots of things need to be into place prior to discharge. We need to plan for routine and acute pediatric care. So we need to figure out how are these families not only going to get home, but how are they going to get to their appointments? We want to make sure that their pediatricians are knowledgeable about NAS and NOWS, they're comfortable with this diagnosis, and that they're going to be accessible to the family as needed, especially immediately after discharge. If mom is positive for hepatitis C, then we need to relay that information and make sure that testing is set up as an outpatient. Ideally, we would be able to get home nursing visits. These babies definitely need developmental pediatrics and early childhood intervention referrals because of the risk of long-term developmental problems. There's also increasing evidence that they can have eye problems, so ophthalmology as an outpatient. Getting the families hooked up with community resources, whether that's through CPS or through our case managers. Mentoring can be really, really helpful. So getting the families hooked up with other families who've been through this. And then really encouraging mom to continue to work with her treatment team, because caring for these infants absolutely can be a source of resilience and a strong motivator for mom to continue in her recovery. So there's a discharge checklist that was published in Pediatrics in 2020 that just hits on all of these issues. So making sure they're not in withdrawal, doing education, emphasizing safe sleep, good follow-up, good referrals. So when talking to the families, we really want to make sure that they know the signs and symptoms of withdrawal and what they can do about it, reemphasizing those non-pharmacologic techniques that we were teaching them in the hospital with the quiet environments and the consoling techniques. Diaper rash can be an issue for these babies because they can have a lot of diarrhea. So aggressively treating diaper rash when it comes on. Getting them to agree and to having people come into their home. Right. So we sometimes have families who don't want early intervention or don't want nurses to come into their home. And really trying to work with the families and trying to understand what their concerns are, while at the same time emphasizing the benefits of having these home services in place. We want to talk about safe sleep education, sleeping on the back, not under heavy blankets, not co-sleeping. And then reiterating when outside of routine care, these infants need to be seeing their pediatricians. Want to work on a healthy home environment. So modifiable risk factors like gun safety, childproofing, getting the number for poison control, locking up prescription medications. And I would say under anticipatory guidance now is locking up all edibles in the same place that you are locking up your medications, trying to identify and address any food insecurities, difficulties getting formula, assessing for exposure to violence in the home or partner violence. And then again, I'm going to say it again because it's really important, making sure that mom remains engaged with her treatment plan, because that's going to be one of the most important things that she can do to optimize the best outcomes for her baby. So what are the long-term effects of in utero opioid exposure? The kind of big answer is we don't know. A lot of the studies are very, very muddy, but taken as a whole, there's some real concerns. So there's growing evidence that these infants are at risk for strabismus, visual acuity problems, nystagmus, refractive errors, and other sort of visual impairments. So that's where follow-up with an ophthalmologist within the first 6 months is going to be important. Neurocognitive outcomes are mixed. And as you can imagine, it's really hard to sort out the prenatal versus environmental factors. But exposed children consistently score lower on total and performance IQ testing. These infants are at a high risk for readmission. The admissions are often longer and cost more. So looking at non-drug exposed infants whose the top cause for readmission was jaundice, those who were drug exposed are more often readmitted for lower respiratory tract infections. And probably most important, injury, trauma, or poisoning was among the top cause of readmission for infants who were in utero drug exposed. A 2019 meta-analysis included 26 studies looking at almost 1,500 children exposed to prenatal opioids versus almost 3,000 controls. And what they found was that in utero opioid exposure had significant association with poor mental and physical development that was seen as early as 6 months, cognitive differences that persisted into early childhood and lower motor scores between 2 and 6 years. But a lot of these outcomes can be improved by fostering resilience in the individual and the family. And I think with close follow-up with developmental pediatrics and the therapist. This was a study out of Tennessee looking at children with a history of NAS versus those without. And they tried to control as much as possible for insurance status, race and ethnicity, age, and public health region of residence, as well as maternal education status. And what you can see is children with a diagnosis of NAS still were much more likely to be referred for special education evaluation, be eligible for services because they were exhibiting developmental delay or speech and language impairments, and they were also more likely to receive accommodations. So looking at the children of heroin-dependent parents versus controls, there were children who were exposed to heroin were more likely to have depression, attention disorder, and more likely to have substance use disorder as young adults. They had poor emotional function with increased rates of oppositional and aggressive behavior, decreased self-esteem and social competence. And then in adults, they saw an increased risk of externalizing behaviors and impulsivity. There's a strong risk of later substance use disorder. We know that substances have unique genetic influences on the risk of abuse. And there was a twin study that looked at multiple substances, and they found that over 50% of the vulnerability to heroin abuse was due to genetic factors. Most of those specific to heroin versus other substances such as amphetamines or marijuana. For other substances of abuse was more strongly associated with non-family environmental factors than with the genetic factors. So again, there's a lack of study on long-term outcomes and many co-founders in all of these studies. But there is evidence that strict supervision during adolescence, decreased exposure to violence, not being exposed to tobacco prenatally can impact resilient behavior and really help these children with their long-term outcomes. Just go over this graph quickly. These are kind of the stages that set people up for addiction. So early on, there's the biologic disposition, the genetics, then there's the maternal exposures during pregnancy, childhood exposures, individual variabilities such as your temperament, your kind of cognitive dysregulation, and then all of these steps then can lead up to addiction. So addiction, as we know, is not just a willpower issue. It is multifaceted, and there are many reasons for addiction that are way outside of the control of the person with the addiction issue. So what about medication-assisted treatment? So there was a trial of 96 children, and they were either exposed to buprenorphine or methadone in utero. At 36 months, there was no difference between the two groups. There was no impact on what treatment they required as newborns for their neonatal abstinence syndrome. And all of the parameters fell within normal range: growth, language development, sensory processing, and temperament. So what this group said was that prenatal opioid agonist exposure is not deleterious to normal physical and mental development. But the study only went up to 3 years of age, and there was not an unexposed infant control group. This was only looking at head-to-head methadone and buprenorphine use in moms. So there is some evidence in the neuro literature that prenatal methadone exposure is associated with fewer white matter tracts and changes in how those tracts are laid down. So microstructural changes in methadone versus control groups. And looking, this was another study that looked at infants born to moms receiving medication-assisted treatment compared to controls whose mothers did not. And it was the majority buprenorphine, but with some methadone. And the moms who were in medication-assisted treatment had infants who had smaller head circumferences compared to unexposed infants. So 30% of infants in the MAT arm had a head circumference that was less than 10 percentile, and only chronic opioid use in mom was a significant risk factor when they looked back at their analysis. So what they concluded was that chronic opioid use during pregnancy, and this was in medication-assisted treatment, so not illicit drug use, that was sufficient to cause neonatal abstinence syndrome is associated with smaller head circumferences at birth. So again, we don't have a lot of long-term, but the studies that are out so far paint a picture that these kids are at high risk for developmental problems as they grow older and really need close follow-up. And this is a very busy slide, and it will be included in the handouts, but this is just what our flow chart looks like here at UVA for how we assess and treat these infants. And it always starts with non-pharmacologic measures, and then the eat, sleep, console approach. The simplified Finnegan is used for NICU patients. So again, those are going to be a different population because they have other medical issues. And then we have the medication arm off to the left and the home in 4 to 5 days off to the right. So non-pharmacologic treatments are the mainstay of treating these infants with NOWS and should always be optimized prior to starting medication. The great thing is that they're family-centered. I'm really focused on decreasing stimuli and feeding on demand. So these are things that the families are going to be able to do at home. Treatment with morphine as needed is indicated as the first-line treatment, and long-term follow-up is crucial. And this is the CME slide for you guys. I'm going to open it up to any questions.
Hey, this is Taylor Katie. I'm a nurse in the NICU. I had a question about, is there any long-term data? I know you said that's limited, but with that Yale study, they used less morphine, but does like less morphine, shorter hospital stay equate to like better long-term outcome, or do we not have that information?
I don't think we have that information yet. I think, if we just started that protocol in earnest, probably in 2018 at some sites, it's still not widespread. That first cohort is just now reaching school age. So it's going to be a while before we figure that out. What they did find was that going to PRN morphine or lower doses did not lead to an increased risk of readmission. But again, that's just short term. It doesn't tell us anything about their long-term developmental outcomes.
Hi, Taylor. I was also going to expand on the short-term benefits. So there was a recently published randomized controlled trial on eat, sleep, console versus other methods. So decreased hospital stay by half, and there's no risk of readmission, ER visits, acute care visits, seizures, non-accidental trauma, or other things. So short term, there's really a very significant benefit to the babies and their families. But long term, as Dr. Holland said, is not yet known. But very many short term and medium term benefits for the babies and their families.
And you would have to, and maybe this will not pan out, but you would hope that if you can normalize care for these infants and get them home as soon as possible, and that they will have better outcomes because hopefully their families will treat them as normal children and get, staying in the hospital for a long time is not great for you on so many different levels. And it really impairs your development no matter what you're in the hospital for. Are there other questions or comments, or people want to share their experiences?
Dr. Holland, would you like to read the question in the chat? And address?
Sure. I was just going to open that up. Actually, let me try to figure out how to do the best way to do that.
I can read
No,
the,
there's a question about risk of rehospitalization. So this was not shown in multiple study, and now we have this large cluster randomized control trial that was just published this July in the New England Journal of Medicine that showed that there's no such risk, no increased risk of admission to the hospital, no increased risk of visit to the ED, no increased risk in visit to the acute care. So none of this panned out as a increased risk for these babies. This is a very large trial. So I think now we have really strong data that's not the case. Actually gave a reference in the chat if you want to look at it more closely. I think it's the second link that I provided that is that paper I was just mentioning.
So the question is, does UVA have a lot of parents who don't stay involved, which would lead to more help in the NICU for these babies? I saw that in West Virginia when I was visiting my god babies in the NICU in Morgantown. No, I feel like we have a pretty good number of families who can be at the bedside. Occasionally we have moms who can't for various reasons, but I would say the majority can. And if not, then we really try to get, like I said, we try to get cuddlers or nursing students or medical students in there with the infants as much as possible. I did want to make a comment about what's going on in West Virginia. I believe it's in Huntington. They have a house that is specifically for the mother baby dyad that is staffed by medical providers, but each room is set up like a nursery. So there's a crib and a rocking chair and dresser, and they can really, the moms can really get in there with their babies and do home care, but in a far more comfortable setting than they can in the hospital or in the NICU. And they're still supported by a full medical staff, but it's a really neat model. Santina, I think this is a question for you. That how accurate is?
Yeah. So screening, screening is accurate, but keeping in mind that screening doesn't equal disease, right? These preterm babies are at much decreased risk of symptoms and signs and symptoms because of multiple reasons. First of all, they have less accumulation. They have immature receptors, so they have their self-physiologic, decrease in opioids because they're going to clear them much slower. They have less fat, less accumulation. So overall, withdrawal in a preterm baby is much less common in baby that's term or that's a larger birth weight. But screening is accurate if you use the cord. For meconium, it can be tricky because a preterm baby may take a lot longer than a term baby to really get to transitional stools. And so then your risk of contamination with urine or other things can be, if you use glycerins or other things like that, can make detection more tricky. But cord is just as accurate in a preterm baby than it is in a term baby.
and just wanted to read it.
I hope that answers the question. Sorry, Sam.
No. Just for folks who can't view the chat, that question was around how accurate is the NOWS screening on the first day of life of a prematurely birth infant. We also have a comment here from one of the NICU nurses at the University of Virginia that says we have a lot of babies who don't have involved parents for various reasons. If the patient is needing lots of care, we involve our cuddlers and PCT CNAs, and when able, are placed in only a 2-baby patient assignment to allow the RN more bandwidth to comfort these babies. So that's reiterating what Dr. Zanelli said. Also, my wife was a baby cuddler and she's now a surgeon. So it's a fun path. Do recommend as a rewarding thing for med students and volunteers to do. Next question we have up for our panelists. I'll read it out loud. Do you find the majority of your patients are in active recovery? I currently have a client that my main work with her is to assist her with getting into active recovery. And she's had relapses, and this is impacting her care for her baby, or her ability to care for her baby.
In my experience, it's mixed. I have some moms who are in active recovery and who are doing really well with that. Often this is not their first baby with NOWS. And so they are good with, staying in the hospital and understand what's going on. And then I have a handful who used illicit substances during pregnancy. So that's a whole different issue. I don't know if Santina, you have any?
No, I think you said exactly what I would have said. I just wanted to answer again, Taylor, with a previous question. This is also emphasize why we don't need to have this be admitted to the NICU unless they have medical reasons, and they should really be, on the PEDS floor or the newborn nursery is appropriate, where the environment is going to be much more conducive to their care. Yeah, I agree with what you just said about the last question.
Another question that and comment here, this may be addressed next week, but how do you manage overfeeding? Also, I've seen problems with infants when mom is nursing and supplementing with formula with inconsistency when nursing, so a fluctuation in symptoms. And maybe Dr. Kellums can weigh in on that one as well.
Yes, we're definitely going to talk about this next week. I would say if they are using a bottle, that we recommend a technique called paced bottle feeding, PACED, and you can just Google that and see a number of videos. But basically what it involves is having the baby root for the bottle, waiting for them to open wide, and then the bottle stays horizontal to the floor such that there's just milk in the nipple and baby has to do all of the drawing and working. And then if they pause suckling, tilting the bottle down so no milk is flowing. And in that way, we think we can both allow them to comfort suckle, but also prevent overfeeding. But I will say, like Dr. Holland said, that most of these kiddos that we see on our service on the newborn side are voraciously hungry and need the calories because they're burning so many with the various tremors and trying to regulate their neurologic system. So usually I don't see overfeeding as a problem.
We have an interesting question here, and this is a management question as much as it is a intervention question, I think. Have you seen interventions to provide additional harm reduction tools to moms upon discharge, such as Narcan, et cetera? If so, has that come from the OB team or the PEDS team, the Gen PEDS team?
I have not given Narcan to a mom. To be honest, her treatment is between her and her provider. I think we could certainly put it into our anticipatory guidance, just kind of in general, having that at the house. But that is not something that I typically do.
Yeah, I think this would have to come from the mom's doctor, since our patient is the child, is the baby. But certainly we can communicate with their team to make sure if we see something that's concerning, make sure that she's, she has appropriate follow-up, and then that the concerns are, put forward to cares for the mom. But as the baby provider, I can't prescribe something for the mom.
Yeah, and I think that's a larger question that we've explored with the toxicology folks and other echoes, and then also in the DEA series, is that finding that balance of, preemptive Narcan, like community outreach. And so balancing that as a provider and finding out the appropriate situations and when to educate for it and where it falls on the care team is a logistically fraught, but also important thing to address. So even if we don't have the answers for that here, I think it was a good poignant question. We probably have time for maybe one more question here. If anybody has anything really pressing or anything you'd like to share that's an important resource maybe that you've been holding back on. Any last questions here? Give it a couple of seconds. All right. Well, with that said, we are right here at 1700 or 5 p.m. Eastern time. So a perfectly timed presentation with some great engagement. I don't really have much to add here other than the CME info will go out with a follow-up email, as will the recording. And then we hope to see everyone back here next Thursday for part 3 and the conclusion of our series, which will be covering breastfeeding, led by Dr. Kellums, but then also Dr. Holland and Dr. Zanelli will be serving as panelists again. So we're so grateful for them. And then lastly, most importantly, let's say thanks to them in the chat and whatever other Zoom emojis here. Let me see if I can find one. Yeah, look, you guys are getting confetti.
Thank you to everyone who logged in at the end of their day.
Yeah, this is such an
It's a big lift on a Thursday afternoon.
Yeah, so grateful for everybody's participation. And then again, it's not too late to register. So share with relevant colleagues for part 3. And so they too can receive the recordings. All right. Well, thanks again, everybody. Great engagement, participation, and wonderful job from Dr. Holland. And thanks again to our other panelists, Dr. Zanelli and Dr. Kellums. See everyone next week, hopefully. Bye.
Thank you.